Okay, terrific. Welcome, everybody. My name is Chaya Kulkarni, and I'm the Director of Infant Mental Health Promotion here at the Hospital for Sick Kids. So thank you for joining us today. Welcome to the next iteration of the 15-part series on infant and early mental health. So a few things. I just want to start, well, actually, just let me make sure. If you're having trouble technically to those who are joining us online, please send an email. Don't try calling. We're not in our offices to pick up the phone. So you need to send an email to us, and Donna's watching the email carefully, so she'll be able to try and work out any kinks that you might have. Also, reminder, if any of you who are here with us today decide to watch one of the sessions later on in the series from your office or home, Donna has created an instructional little video that you can watch so that you know how the software works, how Zoom works, and how you access it. So those are just a couple of reminders for you in terms of accessing the information. So this series started about 5 years ago. We were doing this in partnership with the Public Health Agency of Canada and the CAPC CPMP programs in Ontario. And what we found was that it just increased access so much to information that is really desperately needing to get out and reach practitioners, clinicians across the country in, urban settings, rural settings, remote settings, as much as possible. And so we've continued to offer it. We just found out recently that it looks like our funding for French is going to be approved. So the series will be available in both French and in English, which is always something we're just very excited and happy to be able to do. As we go through the series, for those of you who are here with me at Sick Kids, if you have a question, you just need to tap the little button in front of the microphone that you're sitting at so that everybody, including those who are joining us online, can hear your question. Or if you have a comment, and please don't hesitate to interrupt me, ask questions. Often leads to good discussion. For those of you who are online with us, you have the capacity as well to send in your questions, and Donna is monitoring that and will share that with us as we go through the afternoon. So today is an introduction to the series. You're going to be hearing much more scientific talks, talks from people who are experts in very specific areas related to infant and early mental health as the series goes on. So I just want to start with just some principles that for us are fundamental to the work that we do, but also, out there in the general population, people talk about early mental health, they talk about early childhood. These are some of the statements that are out there, both on a national, international field. Early childhood presents an incomparable window of opportunity to make a difference in a child's life. That's from UNICEF. Mental health in childhood means reaching developmental and emotional milestones and learning healthy social skills and how to cope when there are problems. And the early child period is considered to be the most important developmental phase throughout the lifespan. So, when I read these statements, I feel on the one hand very inspired because I see there are others who have the same passion and commitment that we do at IMP. But on the other hand, I'm always surprised at how surprised others are at this idea of infant and early mental health. Many people, when I say, this is what I do, this is my office, still look at me and say, infants have mental health. People are still surprised that this is so. So this is what we try to work through every day in our work. The history of the online series, we started in 2015, and you can see participation was, it was okay. It was about 500. And then by the time we ended the 2016-2017 series, we had close to 5,000 people registered. Wow, right? Like what what a growth spurt we have seen. And that is exciting. And it's because people like you are talking about it, others in the country are talking about it. So we are starting to get some traction in helping people to understand just how important these early years are to later outcomes for every single child. And not just to mental health outcomes, but to physical health outcomes as well. This just gives you a breakdown of where people are coming from, and absolutely we'd like to see some of those other jurisdictions with bigger representation, other disciplines with bigger representation, but this is not a bad place to be either. So we've literally got representation or participants from coast to coast, which is very exciting. We're reaching pretty diverse audiences, early learning and care, social workers, early interventionists, family therapists, people in the education sector, the medicine, and Ontario early years sector as well. So the objectives for us of the entire series is to provide a level understanding of what we know about infant and early mental health. What are the facts? And I call these things blue sky. Like, these are things that we no longer need to be debate. People shouldn't be debating with us. These are the facts. The science is there, not just in one or two places, but it is now robust. And today I'm going to go through what that is. We want to give you an introduction into the science behind infant and early mental health, and then share with you an overview of what we've learned, because since we started the 2016 series, the IMP team has also been on the road, visiting 15 communities across Canada and documenting how they see infant and early mental health services in their community and where they see the opportunities to strengthen and to grow that capacity. So a quick question, the folks here can just answer putting up their hands. The people who are online with us can answer using their computers. In your agency or community, is the promotion of infant and early mental health a strategic priority? So how many of you here would say yes? So we have a few hands. How many would say no? I'm just here because I'm really interested in this stuff. And how many of you just aren't sure? So a few. Okay. Yeah. Okay, great. Well, hopefully when we finish this, you're going to have some language, some ideas to go back and start sharing with your colleagues as well, and start to get people interested in this. So just some disclosure, you're going to hear a lot today and over the next 15 presentations that are scheduled that will cause you to reflect on some of your own experiences as a parent, as a child, maybe even as a practitioner or clinician, depending on how old you are. Remember, science has come a very long way. Even for me, since I had my kids and they were little, and that was like, 18 years ago, science has come so far, and I look back and there are things that I think, oh, if I only knew, I wouldn't have done that. But we have to be kind to ourselves and not be too hard on yourself. But if something you hear really triggers you or makes you feel upset, it's going to be important that you just connect with someone and talk about that. I always like to be upfront, and I will tell you, much of what we do at this stage is a sales pitch. I'm really trying to sell you on infant mental health, and I think you are to some degree the converted. The fact that you're here tells me you've kind of bought it. I want to sell you enough that you feel excited enough to go back to your agencies and start talking about it with your colleagues, with your management, etc. So to do that, I'm hoping to share with you knowledge about infant mental health, and understanding and acceptance that in fact everybody in this room is a pretty significant influencer of how young children do in our communities and in society. And that in fact this information is going to be incredibly empowering and exciting. And I think it's incredibly hopeful information that we are getting from the science. So let's start by looking at the foundation of infant mental health. So we know that infancy is this profound period of development in the brain, that it's not matched at any other period of time. And so how do we define that? Well, we know every second in a young child's brain between birth and the age of 2, there's 1 million synaptic connections being made in the brain every second. And what that represents is a phenomenal opportunity to influence the architecture of that child's brain. We also know that early experiences, are you okay, Donna? Sorry, I'm just checking in. Yeah. Early experiences, both positive and negative, have a decisive effect on how the brain is wired. Babies do not arrive with all the wiring in place. Relationships drive that process, right? So every interaction you have, a parent have, a caregiver has, all of those collectively are driving those 1 million connections that are being made in the brain. We actually believe that every practitioner who touches young children in any way needs to have a basic understanding of brain development, right? To really understand the kind of opportunity they have. And it will ultimately also mean that they're going to better be able to meet the needs of the children that they're involved with, whatever that capacity might be. And then we also know when young children focus on getting their basic needs met, these connections in the brain mature, while other circuits are going to be lost, unused, not activated. So if all that I can think about is whether or not there's going to be dinner tonight, food on the table, those circuits, those become very strong, very mature. But while I'm thinking about that, there may be many other things going on around me that I'm not paying attention to now. And those circuits go unused. And over time, if they continue to remain unused or not used regularly, therefore not strengthened, they ultimately get pruned away, right? Question, if you can press your button.
Okay.
Hi.
So I just want to get clear in my head before we go too much further. So are we talking about infant mental health strictly from the point of birth?
Yes and no. We are going to be talking at certain points about the prenatal period. Is that what you were asking? Like, are we covering the prenatal period as well?
Yes.
Yeah, there will be speakers who will speak specifically to the prenatal period. I will touch on it today as well. It just isn't a huge focus, but we, and actually to contextualize this, and I want you to feel confident that we get that. Infant mental health is about to go through a pretty big name change, and change in terms of mission, vision, and mandate. And one of those big changes is that we are now prenatal to 5, right? And some of you may be thinking, well, why is that? Why isn't it birth to 3? And part of that is because we know that starting at birth is actually too late. There's a lot that is happening in utero that we can influence. And we need to be talking about that. And stopping at 3 is stopping too early, you know, especially given that they're not often in any kind of system at that point that may be, you know, watching closely their development. So we've extended at the other end to age 5. Yeah, thank you. We know that the greatest opportunity to influence comes in those first 3 years. There's lots of jurisdictions around the world that are doing campaigns that are based on the first 1,000 days. And that, you know, the rationale for that is that we have such a profound opportunity in those first 1,000 days. Relationships drive development. For a young child, a supportive relationship is as important as good nutrition. And the absence of either one of those things has the detrimental impact on development. And I always feel like I need to stress this because I think most of us can really get what it would feel like to be hungry, right? And so the thought of a child being hungry is disturbing to us. It's uncomfortable. We can relate to that kind of feeling. But what people don't necessarily understand as well is that The feeling for a child of not having a secure attachment is as devastating. It is frightening for a child, for a baby, for a toddler to not have that. And it does just as much harm to their development as not having good access to good nutrition on a regular basis. We also know today that when young children experience adversity and don't have that reliable protective caregiver, their physical and mental health and well-being is more likely to be derailed, more likely to end up with negative outcomes. And we're not talking about, you know, next week or next year. We're talking about into their adult years. All right, so this, whatever happens in these first few years, it sticks, and it can influence and impact physical and mental health right across their lifespan. We know maltreatment is harmful at any age, but the inherent vulnerability of infancy causes an amplification of maltreatment's harmful impact. And that goes back to all of that wiring that is taking place in the brain, right? So a child has that, you know, repeated negative experiences. It is influencing those 1 million connections that are being made every second. We know mental disorders do occur among infants, and probably what people may not be as familiar with is that the rates are actually comparable to older children. You know, I am still shocked and surprised when I hear people whom I think, you know, would know about early mental health and its implications when it is derailed. I am still running into people who think about early intervention as something that begins when kids are 15 years old, right? So most people, I think, don't realize that the stats are actually quite comparable. The concept of mental disorders in infancy is largely invisible, partly because I think, who wants to think about a baby having negative experiences, right? It's not something that we like to imagine or, you know, have an image of. When we even say the word baby or infant, we think of that smiling child, right? Innocence, purity. It's all goodness. We know, however, that while the concept of mental disorders in infancy is largely invisible, not recognized in those systems and policies that provide support to this age group. And it's not actually part of the training. I just had a student today who was telling me she was taking a course in a graduate program, in a doctoral program or a master's program, master's. And it was on school mental health. And when she asked if they would deal at all with the early years, even, you know, 3, 4, 5-year-olds, was told, no, that was not part of school mental health, right? So there are systems, there are training bodies. We all need to get on board and start to talk about this. So why is infancy so very unique, right? Well, first of all, infancy, which we define as birth to 3 years, represents a time of particularly rapid brain and behavioral development. We know that atypical trajectories can be identified in the first 6 months of life, and that these can actually predict higher risk for later symptomology. And when severe behavior problems are evident in the first few years of life, there's a moderate to strong continuity of symptoms that place these children at risk for long-term problems, especially in the context of family dysfunction, right? So we have to start paying attention. This idea that it will just go away, they will grow out of it, is not the case for many of these kids. We also know that features of symptoms and disorders in infancy are somewhat different from those in the later years. So when you're looking at an infant, you're looking at not just the child, but the child in the context of the primary caregiving relationship. And your work is focused on that relationship. That's where so much of your time is going to be spent. In comparison, often when we're treating older children, our treatment, our interventions are very much focused on the child. There may be a family component as well, but the primary focus is often on the child, him or herself. We also know that during infancy, stressors on caregivers have particularly immediate consequences for the infant's developing stress response system and overall development. So sensitivity and responsiveness to distress during this first early period, absolutely crucial. This is a unique state of reliance on an attentive, responsive, and sensitive caregiver who essentially becomes the external regulation system for that child. So baby cries because baby's distressed. And really what that is, hey, I am not in a good place right now. I don't know how to get back to a good place or my normal place. And I really need you, my external regulator, my secure attachment relationship, to now step in to help me get back to where I want to be, my usual place. When seeing an infant with disordered behaviors, you're not treating the child, treating that relationship. This is probably the biggest shift for many practitioners. You're tempted to think, I'm gonna, take this child into this room and we're gonna do some play therapy or art therapy or just one-on-one time. If you're not including the primary caregiver, you're missing the moment. You're missing the opportunity. We also know that even from an economic perspective, investing in the early years makes a tremendous amount of stress, of sense. It's stressful when they don't, but it makes sense when they do. And many studies have looked at the economic benefits of early intervention, and it benefits the individual child and family, the immediate community, but society at large as well benefits from that investment. Okay, so let's take a quick poll. There's some mental health disorders that can be avoided if early mental health is better supported. How many of you would say you don't know if that's true? Anyone? That you completely disagree with the statement? How many would somewhat agree? And how many would totally agree? Oh, there we go. Okay. Well, you're the converted, right? Right. So yeah, so the answer, just in case anybody wasn't sure online, is agree. Okay. We also know that some of the disorders that we are talking about in the context of older children are in fact disorders that are preventable, right? So examples of these would be anxiety disorders, ADHD, substance misuse, conduct disorder, and major depression, right? So these are things that we can actually prevent, if we are paying really close attention and intervening early rather than later. Okay. So what is this thing called infant mental health? Well, first of all, sometimes it's referred to as social emotional development as well. It is the developing capacity of the child from birth to 5 years of age to be able to form close and secure adult and peer relationships, experience, manage, and express a full range of emotions, to be able to explore the environment and learn, all in the context of family, community, and culture. When we add the word promotion to this idea of infant mental health, it refers to the promotion of optimal development and well-being in infants 0 to 3 and their families, and the prevention of difficulties and intervention when infants are at risk or have identified problems. So how many of you have in your agency or in your community or personally experienced a young child who's had an identified concern, some sort of developmental concern, who then gets referred to a service and sits on a wait list? Anyone? A few. Everyone, right? And see, this is an example of the system is not reflecting what the science is telling us. The science would say to us, the moment you identify a concern, you need to respond, because remember, 1 million connections every second, we have tremendous opportunity to influence what's happening in this child's brain right this moment, right? So when we refer families or a child to a service and they sit on a wait list, that is missed opportunity. I can't even begin to do the math in terms of 1 million connections every second, 60 seconds in a minute, 60 minutes in an hour, you know, and so on and so on. It's tremendous. But worse than that, and that is bad enough, if you've ever spoken to families who have had this experience of being waitlisted, they feel helpless. And what they really feel is that they themselves cannot help their child, that in fact, they have to wait for some expert to come in to help, and there's nothing they can do until that expert actually arrives. And that's tremendously frustrating and quite disempowering for families as well. So what are the outcomes that we want to see in terms of what we talk about positive mental health? What does that look like to us? Well, it includes secure attachment. That provides the foundation for self-regulation. So we want children to be able to self-regulate. That collectively provides the foundation for resilience, to be able to recover when things don't go quite right. And then, of course, all of that leads to optimal brain development, right? We know that our comfort zone in terms of how and when we look at young children tends to rest largely in the green bubbles, so gross motor and fine motor. You know, I'm sure if I asked people here today, you know, online, the ones that are here with me at Sick Kids, how many of you can describe the steps a child, or the phases this child goes through from the time they're born to being able to walk, right? How many of you think you could kind of articulate the different milestones that a child would experience? Most of you? Pretty, you know. So they sit up first, then maybe they're sort of crawling around, and then they're pulling themselves up, and then they're walking, holding on to furniture, and then ta-da, they're taking that first step without support. So we're not bad at that, right? When we get to language and communication, how are we doing? Are we as strong? I'm not sure where people in the room come from in terms of agency or role, but I'm curious, for those who are working directly with young children, what age are you picking up language and communication concerns? When do you typically start to feel worried? Anyone? Just press your button.
That can be identified very early at infancy.
Yes, but when are people identifying it?
Kindergarten.
How many of you are identifying it in infancy? One. How many of you are identifying it close to when the child turns 2 or 3? Right? Okay, you're right. We can actually pick this up quite early in infancy because there are so many steps happening. Even a baby making eye contact is a step that we expect to see in early infancy. That babbling and cooing and that then going back and forth, we expect to see that pretty early in infancy. And when we don't see it, we need to recognize there's a need for more support. It doesn't mean that they need to be referred to massive services, but it does mean that we need to ramp up that interaction between caregiver and baby to support language development. And if that's not working, then yeah, we need to start making those referrals to the appropriate services. As we go around the circle, we start having less and less awareness or sensitivity to how kids are doing in terms of cognitive development, self-help, emotional, and social development. So these areas are ones that we aren't really recognizing and understanding, especially in the context of normal development and what might be concerning development, and when we need to look more closely. Excuse me. So when we try to define the behavioral areas specifically that we want to be observing, learning about, understanding as we look at a young child, these are the 7 behavioral areas that we want to consider: self-regulation, compliance, communication, adaptability, autonomy, affect, and interaction with people. And when you start to pull it apart like this, I always get to this page and I think, you know, a lot of those things are really hard. You know, they're hard. I know lots of adults who have a hard time with, for instance, self-regulation, right? You know, or even communication. How many of you have ever worked with someone who, gosh, they just have a really hard time articulating what they need, or really, you know, just being specific enough so that I know what they want, right? So these behavioral areas are all areas that children, young children especially, need tremendous support in working through, in developing. Often I find when I say to people, you know, you need to really observe that little one, what tends to happen is people kind of default to that comfort place. Is the child walking, talking, feeding themselves, sort of the more what I would describe as physical attributes of development? That's what they tend to focus on. And if those are happening, conclude that, you know, this little one is doing okay. I'm going to encourage you to use this chart. This was developed by Mary Rella, and Mary is actually doing the next talk in this series, and she will have a different iteration of this chart. For me, this has always helped remind me of what I need to be looking at, observing beyond the obvious physical stuff, right? So what describes the caregiving behaviors that this child is experiencing? Are they sensitive, responsive, the caregiver's available, and reparative when things don't go quite right? Or is the caregiving harsh, punitive, the caregiver's largely unavailable, maybe even for the child frightening, or the caregiver themselves is frightened? Then what does the attachment relationship look like? Is it secure, insecure, disorganized? What is this child doing literally, physically, in relationship to their caregiver? Are they seeking proximity, or are they seeking autonomy? Are they developing shared plans with each other? And then what is happening in the stress response system? So when this little one gets distressed, what happens? Does the caregiver step in and co-regulate with the baby to regulate the baby back down to normal? Or does the caregiver step in and dysregulate along with the child, and now they're dysregulated together? I'll share a little personal anecdote that was happening just before we came in here. I have a kid at university in New Brunswick at Mount Allison, and today her computer died. And her amygdala is really, really, really running fast. And she is completely stressed out. And as I'm talking to her, because she's even having trouble getting through the phone system to the store to get them to look at her computer, I'm realizing, you know, I'm kind of getting frustrated because I think, I've called them, I know you can do this. And I have to remind myself, I have to stay calm for her, because me getting upset is not going to help her to resolve this. So my goal at that point is to stay calm and just keep trying to remind her of what the steps are to work through this problem. I was very grateful to be coming into here because hopefully in 2 hours, she will have calmed down. But, you know, even at that age, she's 19, and I'm seeing that little process and I'm thinking about it. And what I take away from, you know, an experience like today, I remind myself how difficult that is. You know, it's easy to tell a parent to stay calm when their kid gets all worked up or, you know, excited or has a tantrum. It's much harder to do in the moment. And so when I have these moments with one of my kids, it's always a good reminder to me, because I think it's even harder with infants because they can't talk and they can't tell you, right? And then finally, looking at social emotional development, their inter and intrapersonal development, cognition, their communication and social behaviors, their sense of self-efficacy and self-esteem, their sense of self. Do they exude a sense of, I'm a lovable kid or not, right? So I would really encourage you to use this chart as a reminder when you are doing those observations of the kinds of things we really want to be thinking about when we're trying to look at early mental health status. The other challenge of this particular field is that it is interdisciplinary, and that can be a challenge. It's not like we can call in the infant mental health expert, because we don't actually have that designation in this country, right? So you could leave here today and decide that you are now an infant mental health expert, right? And nothing would stop you from doing that. But what that means is that we actually have to draw upon the expertise of many of our colleagues and many disciplines around that circle. You know, I've always had the best results when looking at a child, especially kids who might present with some pretty complex histories and situations and behaviors. When I have as many people who are on this circle, and maybe even others, at the table, understanding, learning, sharing what's going on. If you are trying to understand and resolve what's happening with the child on your own, I think you're going to find it really hard. You need to have those networks that you can reach out to and start to build and bring them in to help you gain perspective and understanding on what might be going on with any particular child. So we've talked a little bit about wait times, and what we're finding often, even when they get to the top of that wait list, it's for an assessment. And then they get to go on another wait list after they've had the assessment that is for service. And that in fact, in some ways, these wait lists actually derail development further, because everybody is left sort of thinking, well, we just have to wait for the service, can't do anything until the service starts. So, so I think we've covered this. Okay, so for us, the opportunity begins early. All of us are too familiar with what experts are describing as a crisis in youth mental health, and I agree, it absolutely is. An estimated 1.2 million children and youth in Canada are affected by mental illness, yet less than 20% will receive the appropriate treatment. That's not a good stat at all. But if we want to change the story, change the narrative about our youth, I think that one way, I'm not saying it's the only way, but I think one way is to embrace the science around infant and early mental health and really start to recognize that if we can support kids early on, it's going to increase the odds for good outcomes when they are youth, right? So we want to increase the chances for every kid to have good outcomes by the time they reach adolescence. And that really does begin early in life. And it means we have to pay more attention, greater attention, and increase our response to those kids who are showing us that they may be vulnerable for poor outcomes. So the challenge, infant mental health is complex, not well known as critical to later outcomes. It goes against the images that we have of babies. It requires an expertise in Canada that is actually quite rare in terms of people who have had formal training in infant and early mental health. It competes against the mental health needs of other populations, such as youth, who are much more able to speak out. And many think there's not much to know about babies. It's really so simple. Just feed them, clothe them, and they will be okay, right? So, what are the facts? The first 0 to 5, critical period of rapid development. Talked about 1 million connections every second in the first few years. The neural connections in the early years provide a foundation for all the connections that form later, right? So if that foundation is not strong, it's going to have an impact on all the connections that happen later on. And the blueprint for the formation of these connections largely depends on the caregiving environment that the child is in. And that is the first place that I will say that includes the prenatal environment as well, right? So we know that even in utero, when children, when that baby is exposed to violence in the home, toxins, high levels of maternal stress, these things have a very direct impact on the development of that baby and ultimately on the outcomes for that baby and the risks that baby may experience. When young children experience adversity in the absence of that protective caregiver, physical and mental well-being may derail. We know that maltreatment is harmful at any age, but of course amplified in infancy, and relationships drive development. Yes.
So I have a quick question from someone online, or maybe for your thoughts. How might you understand how something like ADHD might be preventable through increasing early infant mental health?
Yeah, and I want to be clear that this is not to say that it's preventable for everybody, but to say that we can work at reducing the impact if we start to really observe early on behaviors or indicators that a child may be giving us and respond appropriately. So for instance, a child who is really, even by the time they are 1, unable to pay attention, to stay with one activity for a short period of time, to stay engaged, those may be signs that we need to support that baby in that area of development more, right? So part of this is recognizing those behaviors that may be atypical, not developmental, but atypical given the developmental stage the child is in, and being able, so recognizing them and being able to respond to them. And that is what reduces the incidence of some of those disorders. Okay. So fact number 1, mom's preconception experiences influence baby. So this is before mom has even conceived. If there's a young woman, a woman who's experienced significant stress before conceiving, there is a risk that she is more likely to give birth to a very low birth weight baby, right? And that increases the risk and odds of other health-related situations or conditions, okay? So these women are 38% more likely to have a very low birth weight baby compared to those who are not exposed to stress. And the accumulation of preconception stressful life experiences was associated with low birth weight by many studies, and I've tried to cite those there for you if you want to go and look at that more closely, those who are working with women even before they've conceived. Fact number 2, throughout pregnancy, mom's emotional and physical state will influence her baby, right? So mom's maternal emotional state can impact the in utero physiology and impact the baby across his or her lifespan, right? We know that if a mom has a clinical diagnosis of depression during her pregnancy, she is at a much greater risk of giving birth to a low birth weight baby, number one, but that baby is also going to be more vulnerable to stresses over their lifespan, right? So the risks or the odds of that increase significantly. Fact number 3, infants have mental health when they are born. They show emotion, they respond to comfort, they react differently to different people or voices that they may be familiar with. All of these things are indicators that they actually come into the world with feelings, with emotions, with things, knowing things that comfort them and things that don't. And all of these things are part of mental health. Fact number 4, secure attachment is an essential nutrient for well-being. So the earliest and most significant relationship throughout the lifespan is the secure attachment relationship. It's the foundation for regulation and resilience. And when it is absent, it has a very direct negative impact on later outcomes for that child. So what is attachment? It is that earliest relationship in a child's life. It becomes most clearly evident between months 7 and 9 through proximity seeking and stranger anxiety. You might think about it as a thermostat. So proximity seeking behavior is triggered by the infant's distress. The caregiver, so it goes up, the caregiver's responsiveness and sensitivity brings about feelings of comfort and safety, and the child returns back to their secure base. So their regulation system comes back down. Sometimes people use the words attachment and bonding as if they mean the same thing, and I can't stress to you enough that they don't. They're connected but very different. One of the easiest ways to remember the difference is attachment is typically initiated by the child. Okay, the child has some kind of distress and cues the caregiver, right? Hey, I need you to come in, help me get back to my baseline. Bonding is often actually initiated by the caregiver, right? Caregiver's sense of, wanting to be close, cuddle, the surge of love that they feel. When people talk about singing to that baby or infant massage, these are the kinds of activities that contribute to the bond, right? So they're both important, but the role of secure attachment is very different from bonding. And we know secure attachment is very critical and essential to develop the development of things like regulation capacity and resilience. Any questions, Donna, coming in? Nope. Okay. So attachment is also the template for all future relationships and core beliefs, right? That secure attachment relationship is going to help that child developing a working model for what relationships should look like in his or her world. And sensitive parenting invites children to good quality relationships. Okay. Fact number 5, infants can form an attachment to anyone, right? Good or bad, regardless of the kind of caregiving they've been given, they will have an attachment to that person. So how do you make the distinction between, when it's a secure attachment and when it's not a secure attachment? So I always think about a case that I had heard about when I was in one of our other provinces about a young boy who was about 9, and he had killed his father with a knife. He had stabbed him. And he had done that trying to protect his mom. And his dad had been a violent man, since before he was even born. So his father had died. He had killed him. And people asked him, how do you feel about your dad? So what do you think he said? How do you feel about your dad? What do you think he said? What do you think he said? He missed him. You're close. He said he loved him. Right? So even with all the violence and all the hurt there was still an attachment relationship, right? It wasn't a healthy attachment relationship. It certainly wasn't a secure attachment relationship, but there was an attachment relationship there. So part of what you want to be able to see when you're trying to learn about the relationship between a little one and their primary caregiver is you want to see what happens when there's distress. It's not about watching them when all is going well. It's actually about watching them when all is not going well. So when that baby is distressed and crying, what happens? What does the baby do? What does the caregiver do? What does that interaction look like? That's what you really want to be able to observe. Fact number 6, the development of regulation actually requires relationships, right? So babies begin to develop regulation, you know, the instant they're born. I mean, they have to regulate things like body temperature, heart rate, their respiration rate on their own once they come into the world, right? Those are pretty basic or primitive functions, but they have to do that. Their regulation behavior early on is not a predictor of their capacity to regulate later on. So we have to be careful about making those big assumptions. Their physical systems aren't yet well regulated in infancy. It's going to take time. And most importantly, it's going to require the maturation of the prefrontal cortex. That's the part behind your forehead that is really the thinking part of your brain. And in order to be able to regulate, you actually have to be able to think. You have to be able to do a bit of problem solving, right? So this is going to be difficult for an infant. And just stressing that last bullet there, when kids are dysregulated, so I think about my daughter and the laptop and how dysregulated she was, and literally this is what was going on. Her prefrontal cortex had completely shut down. She was not thinking for even a second. You know, this is a kid doing a major in chemistry, but she couldn't figure out how to use the phone system at Best Buy. Her prefrontal system had shut off because she was so overwhelmed by the stress, right? And so, I mean, this is a 19-year-old who can talk and walk. Imagine for a baby being distressed and not having that comfort, that responsive caregiver step in to help them manage that distress, right? It's overwhelming. Fact number 7, early experiences are life-altering. So an infant's early experiences, including their emotional ones, are going to be wired into the architecture of their brain. And this will include the good experiences and the bad experiences that they have. So let's just watch this little clip.
Anyway, these are Riley's memories, and they're mostly happy, you'll notice, not to brag. But the really important ones are over here. I don't want to get too technical, but these are called core memories. Each one came from a super important time in Riley's life, like when she first scored a goal. Oh, that was so amazing. Look at that. Very nice. And each core memory powers a different aspect of Riley's personality. Like Hockey Island. Goofball Island is my personal favorite.
Come back here, you little monkey! Oh, you're silly.
Yep, Goofball is the best.
Yeah. So I like to share that clip because I think it's pretty amazing that Disney made that movie. For those who don't know, it's called Inside Out. You probably can watch it right online now. It's a few years old. It amazed me because I often still feel like in Canada, we are still trying to figure this stuff out. Early brain development, early mental health. Disney understood it, and they understood it so well, they made an entire movie about it. And I just think that's really remarkable. And I think somehow we have to get people to understand that, you know, some of the things, challenges we see in our young people and our youth, are the direct result of some of their early experiences or the absence of, you know, having somebody be able to observe and recognize that there may be something that needs more support, more care, more attention. So, okay, so little quick poll. Resilience is, so A, if you think this is the right answer, put your hand up. Something children are born with. How many people think kids come into the world resilient? Okay. How many think it's an internal capacity that cannot be changed? So it's fixed. Like the way we used to talk about IQ, it's fixed. You have sort of a set number or limit. No? C, develops over time. Okay, a few more. And then is determined by a child's temperament, with easygoing children being the most resilient. So the right answer is C, it develops over time. And temperament will play a factor in resilience. There's no question about that. But it's not to guarantee that every easygoing child is resilient. And it really is a capacity that builds, I think, across the lifespan, because we're always thrown into different kinds of situations. So every baby is born with the capacity to be resilient, but they are not born resilient. Resilience develops over time. When they experience early adversity, it can be difficult for them to recover without a secure attachment. So that secure attachment is, and the response to distress is what is actually helping to build the resilience in that child. So here's a video. This is from the Center on the Developing Child. If you're looking for additional resources, some additional print resources, videos that you can share or watch for yourself, this is quite a remarkable website, and I would really encourage you to spend a little bit of time when you have some exploring it. But for now, we'll just watch this video on resilience.
Why do some people
Can we
do
turn
well
up the
despite
volume?
serious hardships? The science of resilience can help us find answers.
We define resilience as a good outcome in the face of adversity. The extent to which we can build capacities in all children early in their lives to be able to deal with whatever bumps in the road or major obstacles may be coming down the track, that's an investment in building strong human capital and healthy, productive adults.
Some children face more obstacles and adversity than others.
Is that better?
It's like having a parent with a major mental illness, growing up in a very socioeconomically disadvantaged community, going to schools that are not good, being exposed to violence in the neighborhood or in the home.
But some children do well despite these significant obstacles.
Resilience is that ability or set of capacities for positive adaptation, allowing you to keep in balance.
We're talking about the kinds of capacities and skills and the abilities that give people a sense of mastery and management of difficulty.
It's tempting to think about children as either having this resilient quality or not. But resilience is built over time, just as and in parallel with how the architecture of the brain is built over time.
It's not just in the person. It's in the interaction between the person and the environment.
So we care about resilience for the same reason that we care about promoting healthy development, because in many respects it is the same. We are interested in promoting resilience in children so that, despite the odds, more and more children can grow up to be productive citizens.
So a couple of the speakers in that are actually as part of this series. So Dr. Megan Gunner will be coming in a few weeks, and Phil Fisher is coming much later, I think in June or July. So you'll have a chance to actually meet them and hear them speak. Fact number 9, life before school matters a great deal. You know, I still run into parents mostly who think the real work begins when kids start school. And what we know today is that, in fact, when kids begin school, their developmental trajectory is already established. It's already set in motion. And it is very difficult to change that. So if you can imagine a child who's beginning school already behind his or her peers, the resources required to help that child catch up are often more than the system has to offer. So it's going to be very difficult, right? So we really do need to work harder at making sure we equip children, that we support them to develop so that they are ready to start school. And, you know, a lot of parents will say to me, oh, I guess I have to start doing flashcards. And that's not that's not what we're talking about when we're talking about school readiness. We're actually more interested in kids being able to follow instructions, to listen, to be with other children, to be able to express themselves, to be able to understand the emotions that others show. You know, it's really those 7 behavioral areas that I had shown you at the very beginning. That's what we're thinking about when we think about school readiness. And some of those things are the very things that teachers are actually challenged by in terms of behavior in early learning and care settings, as well as JKSK classrooms. So early experiences matter. The experiences the child has before starting school will influence their development and success once they actually are in school. How many of you are familiar with the Early Development Instrument? So a few. So it's often referred to as the EDI. And for those who don't know about it, again, go online, take a look. It's a remarkable it's a remarkable database of information. And you can zero in on a particular community. I think every province across the country is now using the EDI, and it essentially takes a pulse of children upon entry into kindergarten and how they're doing. And what we've seen is that when comparing 2004 data to 2015, vulnerability has actually increased in physical health and well-being, social competence, and emotional maturity. So risk is greater, right? It has gone down, or we've got improved outcomes in language and cognition and communication and general knowledge, right? So I think we need to spend some time thinking about what we are learning from the EDI and how do we respond to it, right? Because clearly more support is needed. Or, you know, could it be that in 2004, language, cognition, and communication were actually higher in terms of vulnerability, so we focused resources over there to the detriment of other areas. So I think there's some good conversations to have about how we interpret this information, how we think about it in terms of our own practice and what we do with the children we're working with. Fact number 10, we can recognize risk early. We don't have to wait until children are really in a difficult place and, you know, entering maybe the school setting or a childcare setting with lots of behaviors that are concerning or not meeting developmental milestones that we would expect them to, right? And so often those issues go unrecognized, or even if they're recognized, no one has responded to them. And then we expect whatever system we deliver the child into to be able to fix it. And that's pretty difficult. So we have good tools. We can do this early. And I think that's one of the things that we're saying really needs to happen, especially for kids who are vulnerable. Paying attention can change a child's life. We have seen this happen so many times in the work that we do with other agencies, where they start doing things like developmental screening. They're picking up kids who aren't being picked up by anybody else as having risks for poor development. So they're not doing any kind of diagnostic work at all. They're simply recognizing risk, and they're actually responding to it. They may be referring to a wait list, but they're also starting to do some work while kids are on those lists. And they're seeing a difference. They're seeing better outcomes. When we don't respond, that's when we increase the risk for poor mental health later on. I'll play this video clip for you just really to give you some glimpse, some insight into what a depressed baby can look like if you've not seen it. And this is very old footage from the work of Dr. Renee Spitz, who was doing work in the Eastern European orphanages during the Ceausescu regime, where every woman was expected to be either pregnant, trying to get pregnant, or having just had a baby. Families could not support all these babies, and many of them were just abandoned at orphanages. And often, the most consistent caregiver was actually the caretaker, who would come in at the end of every day. It wasn't unusual to see, 2 or 3 babies in one crib. There was no program plan. There was no daily routine. There was no stimulation going on. And you can see that really kind of vacant look in that baby's eyes. And when I first saw this years ago, I thought, thank God we wouldn't see these children here. And as I started to do more and more work in this area, I realized, we have these kids here too. These are kids who have experienced profound and pervasive neglect in the absence of any kind of responsive caregiving. So we actually don't have to go far at all to find these children. Okay, so let's do a quick poll. How would you describe the understanding of those in your agency about the importance of infant and early mental health? So, in case you're worried, a reminder that everybody's answers are anonymous and no one, not even my staff, can ever connect answers with specific participants. So don't be shy. So how many of you would say it's not really, it's non-existent? There's no understanding. Good. How many would say a little bit familiar? A little bit, okay. See somewhat familiar? Few more. And anybody with very familiar? So 1, 2. Okay, great. Fact number 12, in general, the significance of early mental health is not understood. So many infants and toddlers who experience neglect or abuse are not getting the help they need to address their mental health needs. One of the things that we are really excited about for this particular series is that for Ontario, we have Children's Mental Health Ontario. All of their members have been given access to this series. Center of Excellence on Child and Youth Mental Health, their members have also been given access to this series, and the Ontario Association of Children's Aid Society has also been given access, so all of their members. The province of Manitoba, the entire province has been given access. If you're in education, social services, public health, it doesn't matter in Manitoba. They all have access. Similarly, other regions in Alberta, we have a number of trainers, they're being given access. So we're excited because people from different disciplines, different regions are hearing the same information. And that's going to help us get to a common understanding and a shared understanding of how important infant and early mental health is. We can't afford to ignore potential risk for poor mental health early in life. There's a common belief that young children may grow out or outgrow early mental health problems, but we know from longitudinal studies that this is not the case. They don't just disappear. And in fact, the long-term social and economic impact of mental health problems among infants and young children is significant, making infant and early childhood mental health an issue of critical importance for government and communities. Right. Fact number 13, responding early is the right thing to do. When we recognize and respond early to mental health concerns with the appropriate supports and services, it's easier and more likely we will positively influence development. And that's really what we want. Poor mental health can be detected before kids enter the formal school system, right? One of the populations I worry about the most are kids who potentially may receive a diagnosis of fetal alcohol spectrum disorder, because often in many communities, even when there's confirmed exposure, not a lot happens. You know, there are some exemplars in the country where people are really taking a very progressive approach. Here in Toronto, we have Breaking the Cycle, which is an amazing program that specifically is intended to support moms with substance issues, to help them build that relationship with their child. But that is a population that, you know, we sort of don't step in early, and then these kids often get to the school system with lots of challenging behaviors. And the school systems feel overwhelmed by those and aren't able to, in all cases, adequately support that child. So it can be challenging all round. Fact number 15, early adversity matters. And you will hear more about early adversity as the series goes on. You'll hear it from Jean Clinton, who will be doing a session, as well as from Dr. Gunner. And a lot of this comes from the work that was done by Drs. MD and Folletti on the Adverse Childhood Experience study. And you can actually find more information on that on the Center for Disease Control website out of the US. So we know early adversity does not build strength. It increases the likelihood of poor outcomes in all aspects of life: physical, mental health, school success. Early adversity can have a damaging effect on short and long-term outcomes. And when we don't understand a child's context, including their relational history and their lived experiences, our ability to respond to their needs in a meaningful way is significantly compromised, right? So I still encounter people who, when a baby's distressed or going through a very difficult time, will say things like, oh, he won't remember, it's okay. Or, you know, it's going to make them tough. It'll make this kid tougher. And what this research has helped us to understand and confidently talk about is that is not the case. Adversity does not build resilience, right? So that is something that's worth taking a closer look at. Any questions at this point from anyone here? Mm-hmm. Just press your button. Yeah.
So I think something that has come out for me in this conversation is me struggling with the idea of parents coming in and fixing all the child's problems in a way. And I'm just wondering what your opinion is on something like sleep training, or like, you know what I mean? I'm just confused because I feel like there are families that I wouldn't like, that don't have violence per se,
Yeah.
or some of the dramatic examples of adversity that you can come up with, but maybe more common place examples,
everyday things,
everyday examples of adversity. So I'm a little torn. I don't know if you could dive into that a little bit to just.
Well, we're not just going to dive into it. We're doing a whole day on sleep because I am completely baffled by this, what I'm going to call cottage industry of sleep trainers. And, you know, some people will say, you know, part of it is parents not having an understanding of what to expect and when to expect it around sleep. It's also parents who are exhausted. You know, truthfully, honestly, I've been a parent. I've had many sleepless nights. I know it is draining. It is hard. So in that desperate moment, you think, I got to get someone in here to help me deal with this, right? So we're as confused as you today. So we've actually convened a group of experts next month to come together for an entire day and talk about sleep and what are normal and typical sleep patterns that we need to share with families. What are some strategies to promote, you know, sleep routines, healthy sleep routines? and how to respond to challenging sleep. You know, when one of my staff started to look at this, and she's a little bit of a, what I would call a digger. She never likes to do sort of a cursory look at anything. She wants to do the deep dive. And she called me up afterwards and she said, you know, this goes way back. She says, I've been looking at anthropological studies and babies have short sleep cycles. They've had short sleep cycles ever since man existed. You know, so there's something that I think would be news to families, to some families. Oh, this is typical. These short sleep cycles are typical. The other thing for me is, and this is, you know, my own personal bias, that I can't imagine going 10 or 12 hours without food. I really can't. So when I get a parent who says, why isn't my 6-month-old sleeping 10 hours a night? I'm thinking, I'm not really sure I want your 6-month-old sleeping 6 hours a night, because that little brain actually needs nutrition to grow, right? The brain consumes the highest number of calories. So you have to feed the beast, right? So especially for a very young baby, I had a pediatrician call me at one point. She's actually coming to the study day on sleep, and her baby was 4 months old, and she was calling to say she was hiring a sleep trainer. And that was what got me started. I was, what are you talking about? And she said, yeah, my 4-month-old won't sleep. And I said, of course not. It's way too early. And this little person had some pretty significant health issues as well. So the fact that he wasn't sleeping for 7 or 8 hours at a stretch was not a surprise. But in her mind, she was with all these other moms who would talk about how their babies are all sleeping. So I think we have to learn more. And we, meaning literally us at IMP as well, we're going to get together for study day in February. And we're hoping out of that, we're going to be able to put on our website some key messages that you'll be able to share with families. You know, because sleep is a big one. Sleep and eating. Those are the two big ones for families with young children that I think they really struggle with, right? Any other? Yep.
There's a couple of comments and questions from online. So one, just on the topic of sleep again, like they just don't have the community or family supports now to help families manage
that is a good
sleep.
point. Yeah,
that comes with raising.
So I'm just going to repeat that for some families they don't have the support.
Yeah, I've got
oh great, perfect, thanks.
And then another couple of questions. One, how do you define early adversity? And I think we're going to get to that in a little bit. And then the second, where do we find a balance between being responsive and being over responsive in building resilience?
Right.
Like that helicopter parent kind of.
Yeah. And we're going to get to that too. So the first thing, early adversity, we are talking about birth to 5. I think when Dr. Gunner comes, she'll be able to really drill down a little bit more for us in terms of how does that get defined as early adversity, but that's what the literature refers to. And sorry, what was the other point? The second.
Between responsive
and right, and over responsive. And again, I think both Jean and Dr. Gunner will talk about this. You know, we talk about kids experiencing 3 levels of stress: positive stress, tolerable stress, and toxic stress. And positive stress is stress that we actually think is kind of good for them. So sometimes it's good to let kids feel a little bit of stress, but I'm talking about stuff that would be equivalent to, yeah, I had a bad day today at the office, right? We're not talking about something catastrophic. And that this kind of stress actually helps kids to learn how to begin to regulate some of those emotions and some of those feelings, right? So I think part of it is figuring out, you know, what are those kinds of events that your child might go through or a child might go through that are, you know, sort of typical, and child may get stressed, but you know that you want to let them try to solve it on their own a little bit. You don't have to step in to resolve it all for them. It might be initially you're stepping in just to support them to getting to that resolution. So it is something you work at. But yeah, good questions. Those are short answers, but I think those topics are going to come up definitely with Jean's presentation and Dr. Gunner's as well. Okay, anything else here? Okay, so what influences our understanding? Well, the first thing is your own perspective, right? What do you see? Even when you look at something like this, you know, we've all seen these images. Do you see an elephant with 4 legs or an elephant with 6 or 8, or I'm not sure how many I see, 1, 2, 3, 4, 5, 6, 7, 8 legs, you know, and do you see the beautiful lady or the profile of the old woman? So our perspective and how we choose to interpret behavior or development is going to influence how we respond to it, right? So when we look at a child, what are we seeing? Are we seeing behavior that needs to be fixed, a child that needs to be fixed, development that isn't what we expected, families that need to be fixed? Do we see hope or hopelessness? Or do we have more questions about what's happening and what we're seeing? Or is it a bit of everything? Right? And there isn't a right answer to this. You know, so let's just talk first about adversity. Early adversity, and this is what would you answer to this? Early adversity can significantly influence physical and mental health outcomes much later in life. How many would disagree? Some would agree? Agree? Anyone not sure? Don't know? So the answer would be C, that early adversity can significantly influence physical and mental health outcomes later in life. Right. So this is an example of some of the stuff that you'll find on the CDC. So what are the ACEs when we keep talking about adverse childhood experiences? What do those look like? We're talking about abuse, so physical, emotional, sexual abuse, neglect, and that includes both physical and emotional neglect, household dysfunction, could be a family member who is experiencing mental illness, a family member who has been incarcerated, a mother who's been treated violently, family member who is struggling with substance abuse, or divorce or separation. Right, so those are the ACEs that were looked at on these in the study. So this is Dr. Judy Cameron, and she's a neuroscientist, and she's going to talk a little bit more about the ACE study. So hold on, let me just over there on the TV. Okay. I think you adjusted, but
if you look at the child's mental health or physical health, when they're much older, 50, 60 years old, there's a big impact of early life experiences on function.
Can you describe some of that?
Yes, there's been some very good work called the Adverse Childhood Experience Study, or ACE study. And what you see is that children that have had a lot of adversity early in life have a higher probability of having mental health problems like depression. They have a higher probability of addictive disorders. They have a higher probability of diseases that we don't even think have to do with the brain. So they are more likely to be obese, have diabetes, have heart attacks. Early adversity has an effect on how the brain and the body operate, and that's sustained throughout the life.
okay. So they had 17,000 people who had responded to their initial study, and 2/3 had at least one adverse childhood event. 1 in 6 people had 4 or more ACEs, and people with 4 or more ACEs were twice as likely to be smokers and 7 times more likely to be alcoholics. And early adversity was linked to the 10 leading causes of death and disability. Now, I'm always cautious, especially when I'm dealing with US data, US studies. I will tell you that this study was replicated in Alberta and I think in Lethbridge, and their findings were right on target with these, exactly the same. So, you know, the study has been replicated in many different populations, but that is a Canadian study that did replicate these findings. What does it look like across the lifetime, the lifespan? So in early childhood, what we start to see are developmental delays. And the one thing that I will say about this is you have to actually be looking at development, right? To see if there's a delay. And not everybody is well trained in early child development. And if you're not, what you need to ensure you've got are good tools that are going to help you do that, so screening tools, or you've got, you know, one of those other people on that circle who you can call in and has that good training and understanding of early child development to recognize if there are developmental delays. And I include in that social emotional delays, right? And those are much, much harder to pick up in those early years by an untrained eye. So I would encourage you to really broaden your network if you haven't already. And then expulsion from programs. Our office right now is working on a paper with the Center on Child and Youth Mental Health and Mental Health School Assist to look at the mental health of 3 to 6 year olds. And the interest in doing this paper came from anecdotal reports that we were hearing from across the province of young children under 5 being excluded, expelled, suspended from various programs, anything from a preschool program to a childcare program to a JK classroom. Sometimes they'd be also put on modified school days. So it was they could come, but only, you know, for an hour on Tuesdays and an hour on Thursdays. We are also hearing about conversations that suggest to parents, you know, this child might not yet be ready to participate in a group setting. Let's wait another year and see if he's ready. And for some of these kids, actually, what would be very beneficial is to be participating in those kind of settings and getting that additional support. So these anecdotal reports resulted in the creation of a working group to look at the issue. And we're in the thick of writing this paper now, and that will probably be released in the spring. So you'll have a chance to see the results. When we look at adolescents, we start to see things like obesity, mental health issues, suicide, teen pregnancy and STDs, the use of drugs and violence and alcohol, an increase in violence and delinquency. And then by the time they're adults, you can see the list gets much, much longer. And you know, these folks who experience those 4 or more ACEs are also at a much greater risk of dying early. Right? They have shorter lifespans. So can early stress and trauma really have an impact? Sometimes people will say they're too young to understand. However, young children are affected by traumatic events and prolonged and frequent stress. While they may not understand what is happening, the impact on the development of their brain can alter their life outcomes. Age does not protect a child from trauma and the impact it can have on developmental outcomes. So there are neurobiological effects of early childhood trauma. Structurally, we see differences in terms of the size of different parts of the brain. So brain volume is different. We see chemical effects, the dysregulation of stress hormones, the overproduction of certain stress hormones like cortisol, which we know when overproduced can be a real threat to brain development. We see neuropsychological effects, so higher neurological sensitivity to angry, visual, and auditory stimuli. The interesting thing with that particular one is this is what we see in young children. When these kids grow up into their adolescent years, what we see is a blunted emotional response. So here they're hypervigilant, very emotional. They can get upset very quickly. They sense, you know, any kind of anger or threat very, very quickly. 10 years later, no response. So you put them in a situation or event that you think should indicate stress, and they don't exhibit any stress whatsoever. Their emotional reactivity is blunted. And then finally, chromosomal effects. So telomeres are little caps, little protective caps at the end of a DNA strand, and it protects the integrity of our DNA. Now, all of us have these, and for all of us over time, that cap begins to erode just from use, okay? But with children who've experienced significant adversity, we see that deterioration much, much, much faster. It's eroded much more quickly than in another person. Okay, so.
They'd found that if you took a little rat pup and you held it, a human being held it for a very brief period of time, which was stressful to the rat, and put the rat pup back in the litter with the mother, let the rat grow up, and then looked at its brain, it was different than animals that hadn't been handled.
Early in life, many of these connections in the brain, what are called synapses, develop based on genetics, but also based on how experiences occur. And then throughout childhood, the changes in the brain that occur in an interaction between genes and the experiences kids have.
The research on the brain has for the first time given us biological, physical proof that interactional processes that don't go well, for example, impact the brain profoundly.
If the brainstem, for whatever reason, has some insult during development, it could be alcohol exposure in utero, it could be cigarette smoking, it could be prenatal exposure to drug, or it could be significant distress in the caregiver. For whatever reason, if the brainstem is poorly organized and overreactive and dysynchronous, the baby's born, and very often they will have what we call a state regulation problem. They are hard to soothe, that you can't quiet them down very well. It's hard to engage them, and it makes the caregivers feel overwhelmed. They can't calm the child down very well. The child stays all stirred up, and instead of having this smooth, synchronous interaction, you have kind of this bad fit.
When a pregnant mother is under constant stress, you know, she might just be stressed at the office, but her brain and her body and her developing baby's brain don't know the difference between that and that there are predators in the environment. So we're seeing babies being born that are hyperreactive. Why? Mom's under stress during her whole pregnancy, either through work or through being unsupported by her community, by her partner, by her family.
Okay, so you can make a difference. It really is not just what you do, it's not just what you know, it's what you do with the information that you have that is going to make a difference. I often say to, especially to scientists that we come in contact with, you know, it isn't just about telling people about the science, because we can all get, and I think we all do as practitioners, get pretty excited by what the science is teaching us. The challenge is really knowing how to put it into our practice. What does it mean for our practice? When we talk about 1 million connections every second, why should knowing that change my practice, and how would it change my practice? That is really the tough part. So I think one of the first things we are really encouraging people to be doing is to make that referral. If you're concerned about a child's development, make the referral. Let's get the clock ticking, right? We know there's going to be a wait time, so let's get things moving. Worst case, or I guess best case scenario, child's name comes to the top of the list and they no longer need the service. That's okay. It hasn't cost anybody anything, right? I think that the other thing we need to do is there has to be an interim plan within your agency, within your community. So while this child is sitting on this waiting list, here's the plan. Here's what we're going to do. And start to figure out what that might look like. We've been working with a lot of agencies to create this gap plan that we call a developmental support plan, so that the family is given, based on developmental screens and observations and conversations with the family, a plan gets developed that provides a developmental goal and relation-based strategies to support the goal. So that now the parents can go home or the caregivers can go home and they feel that, yes, we can start to do this. We can start to support this particular goal. So we know also that sometimes when a baby is a little late in his or her development, we're not talking about huge, massive, expensive interventions. Often we're talking about reframing the relationship, the interaction, the dynamic, helping families to better recognize a baby's cue, helping a baby to better cue. You know, those can be tough things, right? So it's not always this massive intervention that has to happen. Sometimes it's just that little bit of extra support that can make, in fact, a very significant difference. We tend to spend a lot of time directing and correcting and not enough time actually connecting. And I think if we can even begin by encouraging caregivers, families, anyone who's in that child's world to spend more time connecting with that little one, that is going to make a very significant difference for that child. So what have we learned from the 15 communities across Canada that we have spent time with? First, before we get into the data, quick question. Do you agree or disagree or somewhat agree or agree completely that we have good data about infant and early mental health in Canada? So how many would say they don't know what the data is like? Fair enough. How many would disagree? How many would somewhat agree? Anybody agree? Well, the reality is we do not have good data about infant and early mental health. We actually have very little data. The EDI is that early development instrument is probably one of the richest data sets that we have in the country at this time. There really isn't a lot, and so you'll often see, not just in my presentation, but in many of the presenters, we default to using American data because we just don't have Canadian data, right? So what we started to do with these community tables is actually begin to document, to capture what was happening in local communities in terms of current infant mental health programs, services, initiatives. What were the opportunities that the community could identify to strengthen programs and services? What was the state of knowledge in the community? Who was trained in what? And then organizational policies that actually reflected the nature of the work. I know this person won't mind me sharing this story that happened yesterday on a call that we were having with our partners in several First Nation communities as part of a study we're hoping to begin. We're just waiting on a final approval for some funding. And one of our sites got on the phone and she said, you know, I think I'm going to have to back out of this study. I'm just overwhelmed. We are losing children every day in this community. We are, her words, we are in full-blown crisis. And she was in tears, you know, and we are trying to document and get a picture of what that looks like so that we can help policymakers, decision makers, community leaders really begin to understand that for some communities, this is catastrophic, absolutely catastrophic. So as we work through these, the reports themselves are on our website. They contain the most current profile of infant and early mental health in Canada, multi-sectoral views, because when we do these community tables, we have the community bring together all the sectors. So public health, education, social services, mental health services, anyone they think, you know, we're about to do a table in Niagara, and I was going through the list with our lead there, and they want to include housing. They feel housing needs to be at the table, and you're right. They also want somebody from the maternity ward at the local hospital to be at the table, because they feel that there are some issues and some opportunities to be had in that setting. So then identification of consistent themes, and we have identified those, and opportunities where infant and early mental health can better be supported by the community. In terms of who was at the table, all these sectors and sometimes more other partners, it just depended on who the community lead was able to get to the table. Sometimes we go in, we can't get the school board to the table, or we can't get child protection to the table. And sometimes we go in and we can get everybody at the table. So it varies from community to community. We don't make the decision really about which community. The communities contact us. They let us know that they're ready, that they're committed, that there is some knowledge about infant and early mental health. There's a champion there that we're going to be able to work with. They're going to be able to bring that multidisciplinary lens to the table. And we want to see CAPC and CPMP programs. Those are the Community Action Programs for Children and Canada Prenatal Nutrition Program, both funded by the Public Health Agency of Canada at the federal level. We want to see those programs at the table, because they are actually doing a lot of what we call infant and early mental health. Those staff are doing that work, and they're working with some pretty vulnerable communities and populations. So we want them to be there. So people are invited to participate. The stakeholders are identified. We have templates that we share, and we get to work. We go in for 2 days. We try to extract and document as much as we can. We come back home and we start to put the report together, and we basically go back and forth with everybody at the table until they're all feeling, happy and proud of the report that's been created. So these are the communities that we have been in so far. We are heading, you'll see that Niagara region is at the top. We're actually heading back into Niagara region because when we did the region, the Aboriginal community was not involved. And through later discussion, what they said to us was they wanted their own table. So we're going back in to do a table with the Aboriginal services. The same scenario happened, we haven't done a table yet in Thunder Bay, but we will be going into one of the communities around Thunder Bay, also Indigenous, to do a table with that community as well. So we'll have 2 more tables to add to this list. So a total of 15 communities, over 350 participants, and 225 agencies. And yeah, it's been a pretty remarkable process for us in terms of what we have learned as well. And these are the findings. The current system of supports for families is fractured. We need increased communication and transparency between sectors. Partly why we're so excited that, for instance, the whole province of Manitoba, all sectors are able to access this, that here in Ontario, we have children's mental health, child protection, many public health units participating, many early learning and care settings participating, so that they can all start to talk using the same language. There's a need for more awareness around infant mental health across a wide range of disciplines and professional bodies, including training programs, post-secondary programs. Knowledge is limited and varied, so even those working within the field come from a lot of different backgrounds. So we can't say everybody working with this population of young children has this core body of knowledge. We don't know that. We don't even know what the core body should necessarily be. So that's a challenge. We need to generate a pool of relevant resources for agencies. I was really inspired when we began our work about 6 years ago with child protection, because what I heard from workers was a real commitment, a real desire to do more, but just not sure of what that looked like, because that's not their training. They're not trained in early development, and they're certainly not trained in early mental health. But there was a passion and there was a real willingness and commitment We need to create resources that are actually going to help them do their work, resources that reflect all of that science. Ensuring screening with a strong social emotional component. We don't do this. We don't even do this for kids in care, which for me was just astonishing. This is a vulnerable population of kids, and we are not screening them, even though the science is clearly telling us these kids are at risk for poor outcomes. And if we want to change that, it means really paying close attention to their development right from the beginning, and providing them not with just the usual, but way more than the usual set of supports and services. Waiting lists are a significant concern. Didn't matter where we went, that message we heard everywhere. Transparency is key to collaboration. You can see how, you know, in the name of privacy, it becomes really hard for agencies to share information. Even when parents want them to share information, it becomes challenging. So that was identified as something that they were struggling with. Agencies are not always aware of what's outside their door. This was a bit of a newsflash for us, but you know, I just recently in Toronto, I sat at a meeting with somebody from Child Protection, somebody from Children's Mental Health. And the child protection person said, well, I don't know where to send our kids when we're worried about their mental health. And the children's mental health person said, well, I don't know why you're not sending them to my agency. And the protection person said, well, we used to, and you never took them. And this is a new CEO who said, well, that has changed. You know, but that's right in the city. And so we just need to increase communication, because I think more and more people, as awareness increases, services are opening up for these little ones. We need a shared standard of practice regarding organizational policies and practices. We are actually just about to begin a review of our competency documents. So we've struck a committee from across the country. They will be working with us to revise, probably completely rewrite those given all the science. So that work is going to begin soon. We have to reach out to higher level stakeholders, government, ministry, LINs, to really help, you know, to encourage them to look at policy. Somebody was retelling a story, a conversation they had within a policy and programs branch of a ministry somewhere in the country. And the director says, you know, how much longer are we going to have to do this infant mental health stuff? And the person under the director says, thinks for a minute and says, how long do you think people are going to keep having babies? Right? Like, I think there's still that feeling of, if we do it once, we can stop. And not an understanding at the policy level, actually, we need to embed this into our policy. We are seeing lots of change in jurisdictions. I'm impressed out west in Alberta. They are really looking at changing practice. It's hard work. The teams are working incredibly hard there, but looking at changing policy and practice at the provincial level. And then creating and circulating not just culturally sensitive, but culturally meaning services and resources, right? And this is something, you know, especially in a city like Toronto, we have to get better at doing this. And then communities are taking interest in establishing an evidence base on screening and developmental support planning. So we have a number of studies that are ongoing right now where we are, you know, beginning to collect some very good evidence, very good data, looking at what that means. And then we need more reflective practice and supervision, working with especially vulnerable children between the ages of birth to 5 or prenatal, you know, women who are pregnant and in that vulnerable category. It is very tough work. Emotionally, it is very, very tough. And that's, you know, that phone call that I described with that woman who was overwhelmed, that was vicarious trauma. She was traumatized. I've walked into NICU units in this city and had social workers say to me, I am struggling because I have 2 babies going through withdrawal in 2 different rooms. There's only one of me, and I have to pick which baby I'm going to go into. You know, that I think it's very, very hard, very painful for any of us to go through that. So we really need to think about how we're supporting staff in working with those vulnerable populations. We need a greater emphasis on our Indigenous populations and supporting them. There's limited knowledge on FASD. You know, an example is that now, and I am thrilled about this, families in Ontario receive an envelope of money and they decide what services they're going to purchase for their child with a diagnosis of autism spectrum disorder. We have nothing like that for kids who end up with a diagnosis of FASD, even though the prevalence rates of FASD are higher than autism, ADD, and ADHD put together, right? So we have to keep talking and educating people about what this means, the risk, and we do see higher rates of FASD in Indigenous populations. We need to support those children, support their families. And then the need for culturally sensitive and meaningful resources and services. And that means integrating the perspectives, the views of elders. We're convening a meeting next week here in Toronto with representatives from across Canada, from Aboriginal Head Start, CAPC CPMP programs, among other programs. And all of the reps also were asked to invite an elder to the meeting as well. So that's going to be, I think, a very, very productive meeting. And Adam, sorry. We're currently in the field doing an environmental scan of public awareness messages about infant and early mental health. So if any of you are in agencies or communities and you've done a campaign, we want to hear from you. Please contact us. Our information is on our website. Mentioned we're doing a paper on the mental health of 3 to 6-year-old children. We also have an RCT underway funded by Kids Brain Health Canada. That's well underway now. And we have a study going on in Niagara looking at the implementation of screening and developmental support planning using hand in hand. Sorry. We have also released a call to action on behalf of maltreated infants, toddlers, and preschoolers. This sits on our website. We are in the process of getting agencies to endorse that document, and many already have. So you may want to take a look at that, and if your agency wants to be endorsing that, we would certainly welcome that. We're reviewing our competency guidelines, developing materials to support people working with Indigenous children and their families, doing study days like the sleep day that we're doing shortly, and continuing our work with community table mapping projects in Niagara and Thunder Bay. So I will stop here because I'm also about to lose my voice. And if there are questions, though, I'd certainly welcome any questions or comments, thoughts that you may have. If you're wondering whether we're going to cover a topic, we'd love to hear from you. If there's something you want to make sure gets covered, we'd like to hear that as well. So anything from here and from online? Great.
So yeah, I do have a couple of questions. The first, are there any recommendations for resources to help identify developmental milestones? And the second, is there a link between ACEs in early childhood and later immune issues?
Okay, so the first question, the screening tools that we've been using in our studies are the Ages and Stages questionnaires. So there's two tools, the Ages and Stages Questionnaire 3 and the Ages and Stages Questionnaire Social Emotional 2. So we use both of them. We rely more on the Ages and Stages Social Emotional 2, mainly because we find it to be quite sensitive. It's very helpful. It's tied in to those 7 behavioral areas. So when you're scoring it, you can look at your high scoring questions and it'll actually tell you what behavioral area that particular task or milestone is connected to. So you can start to see a pattern. You know, if you're getting all of your high scores in questions that are focused on regulation, for instance, that's helpful when you start to think about, okay, what is my plan going to look like? What area of development do I need to focus on? So those are the tools that, that we've been using in our studies. The question about ACEs and later immune, whether it affects the immune system, the short answer, yes, it does. An example, for instance, a few years ago, well, it was probably a good 7 or 8 years ago now, the head of social work was looking at the population that came into Sick Kids. And 50% of the kids who come into this hospital come from Toronto's poorest neighborhoods. They have the most admissions and most frequent revisits, right? Because we know that when families, often, not always, but often when families are dealing with poverty, they're also dealing with other issues. You know, poverty alone, one risk factor alone is not enough to derail development. It's when we start to see 2, 3, 4 adversities or risk factors that we start to see an impact. And it does take a toll on physical health, including a child's immune system. Absolutely. And that's where that little cap on the DNA starts to have an impact as well, because that's the integrity of that DNA that's being eroded. And if kids are always spending their time stressed and worried about, you know, is there going to be a fight at home? Is there going to be enough food? Am I going to go to bed hungry? Am I going to go to bed cold? Do we know where I'm going to go to bed tonight? Or is somebody at home going to be angry tonight? You know, when kids spend their time stressed about these things, it absolutely takes a toll on their system. There's, you know, cortisol has a very negative effect on brain development that spills over into the rest of the body. So you can be sure that, you know, kids facing multiple adversities, yeah, they're going to be at a greater risk of having poor health. Not definitively, but the risk increases. Anything else?
One more question. What constitutes a preconception stressful life event?
Homelessness, abuse, neglect, being in a home where there's a lot of violence, even depression, being significantly, you know, having to struggle with depression, especially if you're not getting any help or treatment. I think for, you know, a young person who's feeling bullied, that constitutes a stressful experience, a stressful preconception life experience. So I think, you know, it's anything out of the ordinary kind of stress of, yeah, I had a bad day or I got a bad mark on a test. It's more than that. Yeah. Michelle. Sorry, John, just press the, just so everybody can hear.
Do you think that having a difficult pregnancy or having complications in pregnancy would be something that would be a stressor that would lead to those kinds of issues?
I think it depends on what kind of support systems are around a mom and a family. You know, I think if we're talking about a single mom who's got a lot of those stressors going around and no support, I think it's going to increase, you know, the risk for some difficult situations for that baby, including mom's ability to respond, to recognize and respond to those cues that that baby might be giving. But I think when there's a good support system in place, I think that can be overcome, you know, because if I'm mom and I'm suffering from depression, and when I'm really in the thick of that, my partner or my mother, you know, somebody's able to step in for my baby, that's that protective factor, you know, that's going to buffer that stress. Yeah, thank you. Anything else? Okay, well, thank you very much for coming. Thanks to all of those who are watching online. There is a quiz for people to do. If you're looking to get the certificate at the end, you have to go online and complete those quizzes. I think there's an evaluation as well. Is there? Yep. Yeah. So please make sure you fill that out. And I think our next speaker, if I'm not mistaken, is Dr. Jean Clinton. Nope, it's Mary Rella, who will be focusing on attachment. So she will be the next speaker. So thanks everybody for coming. Have a good week.
I'm just going to make a couple of other
Sure.
little announcements, just because I'm sure we've got had a lot of food for thought for today, and a lot of the things that we've talked about today too will be covered in future sessions with different presenters. But keep the questions coming in. We love that, and also want to encourage everyone who's watching. Each person should register. Make sure that you've registered so we know how many people we're reaching. We're up to over 1,000 participants already, and we hope that number will keep going
So
up.
Donna, just to clarify for people, so if you're in Manitoba or you're getting access through CMHO and through your agency, you still as an individual need to go online and register.
Yes, or if you're watching as a group or, anything like that. And that way, likewise, you'll receive all of the reminders, the session notes directly, and that sort of thing. So the evaluation online, that will come in a reminder email after this session today, and also in subsequent confirmations and session reminder emails as well. So if you have any trouble finding that, feel free to drop us a line at imp.mail@sickids.ca, and we'll be happy to point you to the right direction, okay? And I think that's it, and we'll see you next time.